All right. This topic is especially important as we observe National Women's Health Week from May 12th through the 18th. Just a few reminders before we go ahead and get started. All phone lines are muted. Please enter any questions you have into the question box on your control panel. We will have a Q&A session at the end of the presentation, but please go ahead and submit your questions as you think of them. We'll write them down and we'll be sure to address them at the end. For your convenience, a copy of today's slides has been uploaded into the handout section, which is also located in your control panel. Also, I included a copy of the survey in that section. If anybody has any issues with the automatic survey that pops up at the end, just go ahead and download that now, and you can email it to the email listed at the top of that handout. Speaking of the survey, for those of you who would like to receive continuing education credits, please fill out that survey, and that survey is available in 3 ways. Either in that handout section, you can download it and complete it, or it will pop up at the end of the webinar, or if that's blocked by your pop-up filters, don't worry, we also email it out in the follow-up email. Please only complete one of those 3 methods. You do not have to do all 3. And a special note that we are no longer providing medical continuing education credits. It's just for nursing. If you have any questions or concerns about that, go ahead and email me, Etta Rodriguez, and I'll be sure to answer any questions you have. And then here's a brief introduction to our presenter today. We have Dr. Marianne Burge. She is currently a professor in the School of Social Work, College of Health Professions at the University of Central Florida in Orlando. She formerly worked as a faculty member of the Department of Family Medicine at UF. Dr. Burge's primary research focus throughout her career has been on breast cancer control and access to cancer survivorship care. She is trained as both a medical sociologist and a clinical social worker. Dr. Burge's research and teaching career has spanned preventative medicine, family medicine, and social work. Dr. Burge's current research aims at exploring processes of communication and advocacy across systems of cancer care with the hope of identifying processes leading to more equitable access to quality cancer care and reducing cancer disparities. Her research has been published in a variety of clinical journals. She has worked extensively with interdisciplinary faculty teams and published research on the design and outcomes of interprofessional health education programs. Her most recent book, The Behavioral Health Specialist in Primary Care Skills for Integrative Practice, is used for interdisciplinary health professionals training in the U.S. and abroad. Please join me in welcoming Dr. Burge.
Thank you. So I am very, very happy and honored to have been invited to do the grand rounds here for the Department of Health, and I hope you find it useful information. Okay, so first of all, you already heard some background on me, and what I really want to point out is that because I have been trained as both a clinical social worker and as a medical sociologist, I kind of have 2 different points of view on the work that I do. So as a medical sociologist, I look at social trends in healthcare, as do people in public health. So it's very close to what people and researchers in public health do. So I'm interested in what happens in terms of epidemiology as well as community trends, et cetera, specifically in cancer. As a licensed clinical social worker, I work individually with cancer patients and survivors. So from that perspective, I am very interested in what happens to the individual. And so it's important for you folks who are listening to realize that for people who have cancer, the population trends don't always seem to be relevant to them, because when you're a person who's been diagnosed with cancer, it's a personal story rather than a population story. So I like to put that out there because I think that it's important to remember that every person's story with cancer is an individual story. Whoops, wrong way. So today I'm going to try to do my best to focus on these following things. I'm going to give an overview, starting with the population view of cancer in women and disparities in cancer. I'm going to do an overview of differences in morbidity and mortality across subgroups of women in the population. And I'm reviewing the latest research that I can find from the CDC and from other places. So it's not my scholarship. I'm just, kind of overviewing what's out there, what we know. I'm going to review how some cancer side effects affect different subgroups of women. And then I'm going to kind of start moving into the more kind of individual level of looking at what is quality of life in cancer and after cancer, what's known about how women experience cancer differently. And this really does depend to some degree on gender, race, ethnicity, spirituality, and financial status. And finally, because I'm a social worker, I'm very interested in advocacy, trying to figure out the best ways to go about reducing disparities in cancer and cancer care. So I'm going to talk about some pathways for advocacy. So, our war on cancer has been a long-lasting odyssey. Back in 1971, President Richard Nixon declared a war against cancer. And since then, we've seen extraordinary progress on a lot of levels. We understand better what some of the causes of cancer are, not entirely, but we do have much better science on that these days. And we also have clearly developed some better treatments, more effective, more targeted treatments, and to some degree, some less destructive cancer treatment modalities. Cancer treatment is still not a walk in the park for most people. But today, what I'm really interested in talking about is disparities in cancer outcomes. And I'm going to challenge you all to think about why are disparities persisting over time. So just, if you're in public health, you know this. Health disparities are significant and systemic differences between certain groups in healthcare access and healthcare outcomes. And so those include cancer risk, the risk of getting cancer, cancer screening rates, stage at diagnosis, types of treatments that people receive, and mortality. And I also want you to be thinking about, on the other hand, what is health equity? Health equity is the attainment of the highest level of health for all people, and that's pretty much what all of us are striving for in our profession. And one definition of health equity is that it exists when all people have the opportunity to achieve their full health potential, regardless of race, culture, identity, or where they live. So let's start looking at a few pieces of data that kind of summarize cancer disparities by race and gender. And I'm going to look generally at the population and then zero in on women. So this first graph is SEER data, and it looks at trends in cancer incidence, or new diagnoses of cancer by sex and race between the years of 1975 and 2014. When you look at this graph for a minute, you see some pretty obvious things. First of all, you see that males have higher incidence overall of cancers and continue to over the period of 1975 to 2014. Black males have the highest incidence of cancer. On the other hand, we see that white and black females have been pretty close to each other in terms of new cases of cancer over that period. This is all cancers. Okay, so the incidence rates in women are slightly, it looks like they're slightly increasing over that period, whereas males' incidence rates declined pretty significantly after 1990 or so. Did I miss something there? No, okay. So the good news, disparities in new cancers are declining. Since the mid-1990s, cancer incidence rates for all sites have been declining for both Black and white males, as we saw on the graph. Female incidence rates are lower than men. Overall, they're slightly increasing, but the race difference in incidence for women has been converging over that period. Overall, deaths from cancer have declined in the last 2 decades, especially among Black men. And the excess risk in cancer deaths in Blacks versus whites has dropped pretty significantly from 47% in 1990 to 19% in 2015 among men, and from 21 to 12% among women. So those are good things. But some bad news continues. We do know that African Americans continue to have poorer cancer survival than whites. So the 5-year cancer survival rates, this is really important. I'll show you a table in a minute that demonstrates this. 5-year cancer survival rates, and you all know that that's kind of the benchmark we use for survival, 5 years, are lower in the Black population for all the major cancers compared to the white population. Let me show you specifics. Okay, so these are the 5-year relative survival rates by race, so the percent of people who survive, and the time frame is 2007 to 2013. And we're looking at the most common cancers, right? So, comparing white and Blacks, you see for breast cancer, 92% of whites will survive 5 years compared to 83% of Black patients. That's one of the smallest differences. If you look down the list, there's a huge difference in Black and white survival for specific cancers, most particularly oral cavity and pharyngeal cancers, and uterine cancers, okay? Huge difference. So for uterine cancers, for instance, 85% of white women survive 5 years compared to only 65% of Black women. And you folks in public health are already thinking about some of the reasons for that. There are some obvious reasons, we'll talk about them, and some not so obvious reasons. But the real take-home message here is we got some work to do, right? When you think about across all the major cancers, we still have very big differences in Black and white survival. So, summary, men, especially Black men, have higher rates of new cancers than women. Rates of new cancers in men of both races have declined in the last 2 decades. Black and white women's incidence rates have remained fairly steady and close to each other over the last 2 decades. And I won't be talking much about ethnic groups, but Hispanic, Asian, Pacific Islander, and American Native cancer incidence has been consistently lower than Black and white women's incidence rates. In terms of mortality, deaths have declined overall from cancer in the last 2 decades, especially for Black men. But as I just said, showed you on the table, 5-year cancer survival rates are lower in the Black population than the white population for all the major cancers. So let's talk a little bit about ethnicity, just so I don't miss that. There is a higher incidence of race and ethnicity. Some of the things that are important to think about and wonder about is there's a higher incidence of very aggressive form of breast cancer, the triple negative subtype, among African American women, especially younger African American women. There's a substantially higher rate of prostate cancer incidence and death among African American men than white men. There are higher rates of kidney cancer among American Indian and Alaskan Natives than other racial and ethnic groups. There are higher rates of liver cancer among Asian and Pacific Islanders compared to other racial and ethnic groups. And finally, there are higher rates of cervical cancer incidence and death among Hispanic and African American women than women of other racial ethnic groups. So there are clear disparities across ethnic groups as well. And there are a multiplicity of reasons for these, and unfortunately, we won't have time to go into that today. That's a whole other presentation. Okay, let's talk specifically about breast cancer disparities because that's what I know the most about. All right, so showing you a graph here that shows incidence rates for all cancer sites, first of all, by race and ethnicity for females, for women in the U.S. Just showing you the differences across race and ethnic groups. And what you see are very consistently steady lines in incidence rates, but differences. So, incidence rates, rates of new cancers have not changed much for any subgroup of the population. However, you see there's a consistent difference between ethnic groups. Highest incidence of cancers are among white females, followed by Black females, followed by Asian Pacific Islanders, then Hispanic, and then the indigenous group. That's all right. The American Indians and Alaskan Natives. So it's interesting that there's been no real progress made in reducing incidence rates among women, and that these subgroup differences have persisted for a couple of decades. In terms of breast cancer per se, looking at incidence versus mortality over pretty much the same time period. What do you see here? You see that in terms of new cases, incidence, there's been a little bit of a blip around the 1990s to 2000, but a pretty steady rate of new cases over time. And there's been a very slight decrease in mortality over time. So that's pretty good information and news for us. When you start looking at survival in the population, breast cancer is one of those cancers where we have very good 5-year survival rates. Almost 90% of women who get breast cancer in the total population, that is, survive 5 years. So that's very good news. Let's look at the deaths by race and ethnicity. Again, we got to be very clear that there's a huge disparity, and the biggest disparity is in race. So Black women are much more likely to die from breast cancer than white women, and that difference has persisted over time. So, what we do know is that there are a variety of factors that go into this problem of understanding disparities in cancer outcomes. So, first of all, genetics has something to do with it. And luckily now we have good science that's doing genetic tests on cancers. And to some degree, we're able to target cancer therapies depending on your gene profile to a small degree, which is good from the treatment end. We certainly know that genetics play into development of cancer to some degree. We also know that the environment certainly can trigger new cancers. Very hard to understand that pathway because it's there are a lot of variables that go into it, and it happens over time. My first job was in preventive medicine on a National Cancer Institute grant, where in Long Island back in the 1980s, and there were very high rates of breast cancer in Long Island. They were trying to understand it. And a lot of people in Long Island, women, believed that it was something in the environment that was causing it. And so the NCI pumped huge amounts of money into studies of the environment in Long Island, as well as looking at access to care and use of screening. And they really didn't find a thing in the environment because it's very hard to really identify the pathways, because you've got environmental exposures, obviously, from the time you're born forward. So they weren't successful in finding that. So the environment we know has a lot probably to do with the triggering of cancers, but we don't understand it very well. I'd also like to point out that the environment is not just toxic emissions we're talking about here. There are other things which I'll get to soon. Healthcare access, obviously, is an issue that can play into the problem of disparities, and I'm going to talk about that a bit. And then finally, socioeconomic status, which is connected to healthcare access as well as to environmental issues, is important to look at in terms of disparities. And I like to point out that most of these things are not within a patient's control. A lot of patients, when you're working with them individually, the first thing they start thinking of when they get a diagnosis is, what did I do? What could I have done better? You know, maybe if I hadn't smoked, or if I hadn't been exposed to, and it's unfortunately something that is unanswerable for most patients, and it's also important to point out that most of cancer incidents, new cancers, are not within your control. Okay, so first of all, let's look at the system of care and disparities. I have cited a really great article down here that kind of summarizes the research on breast cancer disparities by Reader Hayes et al. So what the research tells us at this point, that breast cancer disparities are related to, not surprisingly, delayed care. So getting into a doctor late and getting a late stage of diagnosis, limited ability to pay for care, or inability to complete treatment, which is often a result of financial problems. Okay. So uninsured women are much more likely to have delays in resolution, specifically of abnormal mammographic findings. So they may get the option, the access to a mammography, but they may not have the greatest access to a good radiologist and prompt findings from a radiology site. So that's a problem in staging. Black women in Medicaid or Medicare are more likely to experience delays in surgical treatment than white women. Now, why would that be? I can't answer the question absolutely, but there's a lot of good research that shows that there are delays in surgical treatment among Black women.
Can I just say, because we've got all these factors.
Yes.
But also what's a factor, even if you've got good medical insurance, in terms of race, you tend not to be treated the same as a white female and treated with respect. And if you've got aches and pains, they're very dismissive, very patronizing, and I found that I'm coming into a new country, I've got brilliant insurance, not Department of Health insurance, but it's the same thing time and time again, and a lot of women may not be confident or assertive to speak up, but it's a battle time and time again. It's the total disrespect because of my
yes.
gender and my race.
Absolutely.
And that's a major factor.
And age.
Yeah, it's a major factor.
I might also add body size. Okay. So there are absolutely reasons that we know of, especially if you've been a woman in that position experiencing health care. You can see that you're not getting listened to, you're not given the opportunity to ask questions, you're not being given the information you need. Absolutely. Absolutely. And are you from the UK?
Yes.
Did you have that experience in the UK health system?
No, but you do have a long wait.
Can you speak a little louder?
Okay. So in the UK, everyone who's accessing the NHS system, the free medical system, has a long wait, and there is a disparity between social areas. If you live in a wealthy area, you have better access to medical care and faster access.
Gotcha. But you don't see the race differential in terms of care, quality of care, or communication so much.
No.
Okay.
Someone else may do, but I haven't.
Okay.
But there's a big difference from here and the UK.
I'm sure it's been a huge shock to you coming here.
Yes, it has.
Sorry. I'm sorry. Okay, to go forward, and I appreciate you bringing up that information, and that's, research backs you up, okay? Different communication depending on race, similarity or lack of between the provider and the patient. Surgical delays are more common in states, so there are geographical differences. Surgical delays are more common in states with less generous Medicaid reimbursement. Not a big surprise, right? And the quality of surgical therapy also differs by race. And that is primarily because we think that the institutions where minority patients can get care have different levels of quality than other institutions. And so this is more from that particular article, the Reader Hayes article, which I think is so good in summarizing these issues of the system of care and how it affects disparities. But they're just summarizing the research here in terms of what they think is the most important issues in the system of care in terms of creating disparities. And you can see that the first one is that women present with more aggressive disease and delayed diagnoses, women of color, and that the second one is inadequate surgical therapy, including very specific things like not staging axillary nodes, for instance. Why is that not happening at the same rate of for women of different color? And delayed surgery, failure to receive radiation for node-positive disease, failure to receive radiation after lumpectomy. Now, some of this could have something to do with out-of-pocket costs and ability to cover them, depending on your insurance or your underinsurance. Inadequate chemotherapy. So right on down the line in terms of the continuum of care, there are disparities in the system of care and what women get. And the most important thing to me to realize is that disparities have just persisted over time. We're not taking care of it yet. If you look at the period 1975 to 2013, we just have the same pattern. So you can see that incidence in women of color have increased and kind of tabled off, and mortality has declined, but there's still the differences. And so the widening, and there's actually a widening in mortality between Black and white women over time. So the gap is increasing to some degree, and that's really important. And it also points to the possibility that post-diagnosis factors are really important in terms of mortality and survival. So what happens to you once you've been diagnosed and forward? So we all know, too, that there are a bunch of reasons that play into this disparity problem. Food insecurity, poor access to quality health care, smoking, physical inactivity is a risk factor for breast cancer mortality, availability of affordable health care, smoke-free policies, payments to states from Medicaid, and obesity. So these have been found to be risk factors for disparities in cancer. And I'm a big proponent of really looking at the financial factors affecting cancer care, okay? I think that's one of the major things we could have some kind of input on and make differences in. So we absolutely know that individuals from medically underserved populations are more likely to be diagnosed with later stage cancers, which means that your risk for mortality is higher, and people with low socioeconomic status have higher cancer death rates regardless of race and ethnicity. So if you're poor, you're in a bad situation for surviving cancer. This is a nice graph from the Kaiser Health Foundation. It shows that the percent of people who report that they delay or go without medical care due to costs. Pretty simple. Uninsured people do at a much higher rate than people who are insured or underinsured. That's a pretty simple equation. This is interesting in terms of out-of-pocket spending. It's important to realize that cancer diagnoses are out-of-pocket spending is a very big problem in cancer diagnoses. I love hearing about people who have great insurance and go through cancer care and treatment and say, I didn't have to pay a thing. But that's a small part of our population, okay? Out-of-pocket spending is very problematic in cancer, especially for the lymphatic cancers, colorectal cancers, ovarian, and the three female cancers, ovarian and breast cancer and uterine. So just remember, you may have insurance, but if you have out-of-pocket expenses that you cannot afford, what do? You usually delay treatment or cut out of treatment altogether. And I also like to point out the upstream causes of cancer disparities. We cannot forget that even in terms of actual incidence of cancer, new cancers may be affected by the social environment. There's some fairly good research now that shows that not only poverty and low socioeconomic status, but social injustice, responses to the continual stress of being oppressed in our country is a bad thing for people's health. And I'm going to show you in a minute how it can actually be, you can see how it can be tied to the development of cancer and the likelihood of surviving cancer. So, for instance, we were talking earlier about the ER breast cancer incidence among women. There's some good research that shows that women in states with Jim Crow laws, which limited Black advancements and freedoms, obviously, have higher levels of disparities in cancer outcomes than states with less of that kind of laws or history. Also, early childhood abuse and neglect, interestingly enough, is something that's associated with elevated markers of inflammation among breast cancer survivors. So it's what's the connection here? I'll show you in a minute what most people are seeing as the connection. Also, women who experience social isolation before their diagnosis have a 66% increase in all-cause mortality in breast cancer. Social isolation. Fascinating. So this brings us to minority stress theory. And this is a really kind of useful way of looking at cancer disparities, I believe. And it postulates that there's a great deal of stress associated with being oppressed or being victimized, both personally and by policies. And that prejudice and stigma directed towards people in oppressed groups brings about unique stressors, and I must say also persistent and continual stressors that cause adverse health conditions and may predispose you to certain cancers. So this is a very nice slide. I borrowed it from Hinsey et al. And it says, and it's actually, the article is titled, Getting By with a Little Help from Our Friends. The whole field of psychoneuroimmunology is very important in thinking about minority stress theory and its effect on cancer. And so they start with social isolation, and they talk about how the brain actually responds to the stress of social isolation. You could also plug in, besides social isolation, violence, for instance. And it actually increases certain brain chemicals which will change your immune response and suppress natural killer cells, et cetera, and increases your risk for mortality through increasing tumor grades and increases metastases in cancer. So actually your social environment, how you grew up, what you experienced in your environment, and the stress of that can actually increase your risk of cancer and metastatic cancer. At least that's the theory. So I also like to point out that cancer survival is relative. As I was saying before, no two patients are exactly alike, and all treatment and responses to treatment can vary greatly. So you can't say that all people who experience early childhood violence are going to have terrible outcomes. I mean, to be clear, that's just kind of a trend we're seeing. And from an individual level, it can be very different. I'm going to switch now to kind of look more at the individual level and the experience of cancer. So quality of life, you've all heard of that. It's becoming a marker now for healthcare and quality healthcare. It's a subjective phenomena. It can be defined, and I like this definition a lot, as the difference, quality of life is the difference between an individual's hope and expectations and his or her current life experience. So it's subjective and relative. So it's something that happens within the individual and how they experience life. And when you look at the research on quality of life, there are 4 primary domains that people look at, obviously physical, psychological, spiritual, and social. Now I'm going to talk about very quickly, I'll talk about 2 studies that I did that really looked at quality of life of cancer survivors. This first one, background, American Cancer Society did several cross-sectional surveys of cancer survivors, national surveys by telephone, and they've published a whole bunch of articles off of those. I talked to the guy at ACS in Atlanta who was running that research section. I said, I looked at your survey, there were 3 open-ended questions at the end. Has anyone ever published anything off of those? He said, no. And I said, well, why not? He said, because it's too much data. You know, it's open-ended, it's qualitative. No one can handle that. So I, of course, foolishly said, well, people answered these. Someone should be looking at what their answers were. So I put together my team, and Gail Adorno is a social worker. Ellen Lopez has a doctorate in public health. Vicki Lortzel is a nurse. Kevin Stein is a psychologist. And then there are 2 graduate students. So we had a real interdisciplinary team to go about doing a qualitative, and we did a mixed methods analysis of this data. It turns out there was a lot of it. So for this particular question that was asked on the survey, what are your current unmet needs as a cancer survivor? And they looked at cancer survivors who were as much as 10 years out from their diagnosis. And they asked them open-ended, what are your current needs? So what we did was we took that data, did a qualitative analysis, put it into the themes, and then looked in a mixed methods way at how themes in their current problems were associated with time since diagnosis, race, ethnicity, et cetera. So these were the top continuing problems of cancer survivors. Oh, I didn't put the N in this. There were, I think, around 1,500 responses to this question. A huge amount of qualitative data to handle. My team worked across the country. We're all in different places. We'd have phone calls every Friday afternoon. We worked in teams coding the data. It was crazy. Went on for months. These were the problems that came up. Continuing problems with physical problems, pain, symptoms, sexual dysfunction, and care of the body. Second were financial problems. So these were people who had been diagnosed from 2 years back to 10 years back, okay? Financial problems were still a big, 20% of these survivors said they still had financial problems, and so on. I'm not going to read through this whole thing. But I'm going to now skip to the associations with who were the most likely to have these problems. Physical problems, men and older survivors. A lot of the men with prostate cancer were talking about their side effects that continued, persisted well after their cancer treatment. And we don't have enough research being done on that. People need to start looking more at prostate cancer and outcomes because it's tough stuff. But in terms of women, especially breast cancer survivors, the financial issues were the top problem. Okay, persistent financial issues, especially among women who were young and Black and Hispanic. Okay, we didn't find significant differences in information needed, but we did find that women had bigger problems with the healthcare system and accessing it. So we did one more study, and this was more of a quality of life study. Another open-ended question in that survey was, what are the positive aspects of having had cancer, of your having had cancer? And there were even more responses to this. There were about 5,000 some responses. And my team, Gail Adorno, took the lead on this one. And these are some of the positive things that came out. So it's about a quarter of the people said that gratitude was a theme that really persisted since their treatment. Appreciation, etc. Spirituality was the third. Relationships. So you can see, though, that in the last column, that women were most likely to say that they appreciate and valued life more since they had cancer than before they had cancer. And interesting, Black women survivors were more likely to point out that spirituality was a major theme in what they now feel was a benefit from having had cancer. Did you have a question? 5 minutes, okay. So this data, these two studies really get at kind of the individual experience of having had cancer. And what I really think is important, what we found was that the individual experience did not, I had hypothesized that problems would be less and less and different as you went over your years post-treatment. So survivors who are 10 years out would have fewer problems than survivors 2 years out from their treatment. Well, in terms of these open-ended responses, that was not borne out. It didn't matter how long it had been since you'd been treated for cancer. You were still having these problems or still experiencing these positive aspects. But we did find differences between women and men and to some degree in race. So what predicts good quality of life in breast cancer survivors? The research shows the following things. Having high levels of social support. There we go back to social support versus social isolation. Very important in terms of health. And the second one is good patient-physician communication. A huge issue, especially these days. Even people with the best health insurance often have very fragmented care. So I have a brother who's in the VA system, and he says, I never see the same doctor from one time to another. He's going for prostate cancer. That makes it difficult, right? And I'm sure some of you have had that same experience. So he has great coverage, but no continuity of care. So how do you communicate well? So those are the things that seem to predict quality of life in breast cancer. For some reason, I don't think there's a lot of research on it yet. Women who are of Hispanic origin or Asian Pacific Islanders seem to express higher quality of life than other groups. Not sure why. And lower levels of cancer-related financial burden is not a big surprise, is a predictor of quality of life. So pathways to equity in cancer. I think these are the major ones. We've got to increase access to cancer care across the whole continuum of cancer care. That means from the time that you get in for a mammogram, if it's breast cancer, to follow-up care, okay, after you've been treated. We have huge need for improvements in that. The research does show that patient navigation in cancer care works very well. So especially for, the lower income groups who have really a hard time accessing good care, patient navigation can make a huge difference. And there's been a lot of money pumped into patient navigation programs. Unfortunately, most patient navigation programs are grant funded, which means guess what? They last for a while and then they go away. Okay. And also another great pathway for reducing disparities is to reduce some of the risk factors, which are more of social problems, increasing research into environmental exposures, increasing access to healthy foods, and increasing options for physical activity. Okay, and more higher level system or systematic things we need to do to reduce disparities. Obviously, improving access to screening. But more importantly, I think, and more doable at the moment is allow for Medicaid expansion. We all know that Florida has not allowed Medicaid expansion. They won't be doing it this year. Hopefully, the legislature can be convinced to do it or start working on it next year. Patient navigation programs, more of those and consistent ones. And then really getting providers to think about their clinical practice and how they can improve it for all patients. There's a lot of discussion in medical schools about patient communication, but I don't think there's enough. And also I mentioned there, promoting adoption of guideline concordant care by providers. And I have found in my experience that the same person with pretty much the same cancer profile will have very different experiences with different providers in terms of what their recommendations are. It's not really clear why. Reduced cost barriers, absolutely. I mean, that's a given. And you can see that out-of-pocket expenses are nearly double for people undergoing cancer treatment than for other types of problems. And particularly Florida has a very high cancer burden. The Department of Health says that we have the second highest cancer burden in the nation. It's the leading cause, and I find this hard to believe, and if someone has better information, but as of 2011, cancer was considered the leading cause of death for Floridians, surpassing heart disease. That's pretty amazing. I don't know if that's still true or not. I haven't seen good information. And Florida has the nation's second highest rate of uninsured residents under 65, which is a problem in terms of access to care. So what do? We advocate for change. I'm just going to put out a couple of things you could consider if you're interested in advocacy. The American Cancer Society has a really good advocacy arm now. And one of the things they're working on right now is the Henrietta Lacks Enhancing Cancer Research Act. And you can call your legislators and ask them to vote for this. This includes trying to figure out and get better participation of persons of color in clinical trials, which has been a persistent problem for some very good reasons. But we need people of color in clinical trials to get good information about treatment. This is an organization I'm actually involved with. I'm on the board of directors of Breast Cancer Action. It comes out of San Francisco. And they also are great advocacy people, specifically for breast cancer. One of the things we're working on right now is the Lymphedema Treatment Act. So women who have breast cancer, especially surgical treatment, often have lymphedema, which is a swelling of the lymph glands. And it can happen immediately after treatment. It can happen 10 years after treatment. The problem is doctors don't talk to patients about this. And the other problem is that the main treatment for lymphedema are compression sleeves, and they are not billable under Medicare. They have to be paid for out of pocket, and they're quite expensive. So this Lymphedema Treatment Act is an effort to try to get Medicare to at least cover compression sleeves. And there's a lot more work to be done, and women of color have higher rates of lymphedema than other women. So there's another problem in terms of disparities. And I think that's it. Yes.
We'll take any questions from within the room. If there's no questions from within the room, anybody who wants to chat them in, please go ahead and do so.
We already have some. I see the no.
From watching.
Let's see.
Please speak loudly so they can hear you.
I'm going to follow up on that data for the state.
Yes, please
I
do.
will find that out and I will send it.
I looked that up, I think it was last year, and that's where, what I found last year, but I was like, geez, I just didn't feel real confident about that, so I would love to find out,
For
yeah.
sure, I will find out. Just a quick question, when you talked about the minority stress theory,
Yes.
where did that come from? Is that something that is kind of, who
Did I not,
created-
did I not put a citation there?
I think you might have, I just missed it.
Okay,
From,
I don't know if I put one there, but I'll look back and see. If I didn't, I will send some out. But it's a fairly well-known, I didn't. Okay, at least in social science circles now, a lot of people are using this theory. A lot of our doctoral students actually at UCF now are doing studies of discrimination and disparities, and this is a primary theory that people are basing it on. And the nice thing about it is it's not just kind of theoretical. The psychoneuroimmunology folks are kind of backing it up with real data that stress, especially accumulated stress, there's been some good studies of women, Black women with cancer in Chicago, and they've been able to associate levels of violence and isolation with rates of the aggressive cancer, triple negative cancer.
So our next question starts from Miss Baker, and she said, when I was diagnosed, the doctors told me I was depressed and needed to be on anti-anxiety medications. I did not follow this recommendation. I have survived, but how often are mental illnesses diagnosed during cancer treatment? The doctor actually said I had cancer because I am a worrier.
Wow. Let's blame the patient. That's a horror story. Probably not unusual. I'll answer the first part, though. There's very good data that's been done for about 2 decades now, looking at the stress during cancer, levels of distress and mental health problems. And absolutely, there are higher, not unexpectedly, levels of anxiety from diagnosis forward. And also, I might add, every time a person goes back for a checkup after being treated for cancer, it's a place where often people feel extreme anxiety and sometimes depression. So absolutely, mental health is a concern, and it's good that oncologists are concerned about mental health. The other thing they should be concerned about are relationships. So people who have cancer often have impaired relationships with family and friends because their lives have been disrupted in a lot of ways, and people don't know what to do about it. There's legislation, well, it's not legislation, the American College of Surgeons, which is the group that is the accreditation body for cancer treatment centers, which do surgery. They now require all cancer surgical centers to do distress screening, they call it, with every patient, which means it's a good idea in principle, but in execution, it's not so great. So at some point in your from diagnosis through treatment, as a patient in an accredited surgical center, you're supposed to get a screen, a psychological screen, to measure your distress, your psychological distress. Now, what do you do with that? Is the question. All they have to do is screen. There's no directive about how to follow up with that. And so it's kind of, an empty gesture unless it's taken somewhere and used in some way. There's a lot being published about that. I've published them on that. And the problem is there are different types of screens being used across different centers, and some people are following up with patients, lots aren't. It's very strange. It's a good idea, but it's the execution that is not working out so well.
So our next 2 questions are about addressing the disparities. The first wants to know, what strategies do you recommend for public health officers and leaders to take in Florida to bridge the gaps we see with these cancer disparities? And then the second is, what steps can be taken to just decrease the disparities other than the ones you've already.
Yeah, and I know it's hard to be political when you work for the Department of Health, but I will have to say that access to care is the primary thing, to the most immediate approach, I believe, to addressing disparities. So making sure that people have insurance and can get good quality care. There's a great study out of Chicago. They had the biggest disparities between Black and white women back in the early 1990s. And they have had the best success of a public health program I've ever seen. They've almost entirely reduced Black-white breast cancer disparities over about 10 years. I didn't bring a citation for that, but I can give that to you. But just look up the Chicago breast cancer study. And what they did was they made it a priority in Chicago back in 1990s. They said, we have almost the biggest disparity in the country between Black and white women's mortality. What are we going to do about it? And they got a huge citywide community effort to look at the problem, collect data, and then start working with the providers on every level to start collecting data and to look at where the gaps in care were, okay? So they found out that poor minority women were less likely, for instance, after getting a mammography, to get a reading, okay? So there's a big gap in care. Unless you get a radiologist looking at your mammography, you're not going to get any care. So that was a big gap in care. So they identified all the specific gaps in care along the continuum of treatment, and they worked as an urban community of providers on every level, the public health department, the oncology providers, the researchers. They put together a consortium, and they actually have managed to almost decrease disparities between Black and white women's mortality. So a huge effort, but it's doable.
Our next question is, they want to know what age to start getting mammograms. They've heard conflicting ages.
I'm not going to recommend that. The guidelines, as all of you know, probably have changed often. And it depends on which guideline group you're talking to, American Cancer Society versus the National Cancer Institute or the American College of Surgeons. So I recommend to people to look those different groups up and talk to their primary care person and make a decision based on their own history.
We don't have any more questions right now, so, okay.
I've got one. If you go back to the first chart there, you had in the 1990s, you had an increase in both male cancer rates, it looked like. It was a big jump in the 90s.
Yes.
Well, can you contribute that to an item or a
I am guessing,
there you go, right there.
yes, that one. What would you guess? You want to make a guess?
1990s, it was increased awareness of prostate cancer?
Diagnosing a prostate cancer,
Okay.
for sure.
Okay.
I think also we had a bigger decrease in smoking around that age. I think, I'm not sure, but I think that cigarette use started dropping maybe before that time, but certainly that might contribute to that as well. Because lung cancer obviously is one of the big cancers. So, but I think prostate cancer screening is probably a big one there. Yeah. And prostate cancer survival is very good. So if you get screened and treated, you have pretty good survival from prostate cancer. So, okay. Is that it?
This looks like a comment. I'll let you read after.
Okay.
But that seems to be the end of our questions, so we're going to wrap up today's presentation. Thank you, everybody who joined us. I just wanted to make a second announcement about the continuing education credits. If you would like to receive them, you do need to complete the survey. There's 4 ways. If you're in person, complete the paper handouts that should be in whatever room you're joining us from. Or if you're joining us via the webinar, you can either download the survey from the handout section, you can complete the survey that will pop up when this webinar ends, or you can complete the survey that's sent to you in the email follow-up. You do not have to complete all 3, just complete one. We are only providing continuing education credits for nurses. We do not provide the medical physician continuing education credits any longer. To get that credit, please include your name, your license number, and the prefix to your license, such as RN or whatever other ones you may have. If you have any difficulties with this survey, please email me, Etta Rodriguez, edda.rodriguez@flhealth.gov, or you can email the Florida Health Grand Rounds email that is on the top of that paper handout survey. A second note that the Grand Rounds will be breaking for summer and presentations will resume in the fall. For up-to-date information on our presentations and our fall series, please visit the Florida Health Grand Rounds website. Thank you all for joining us today, and a special thank you to Dr. Mary Ann Berg.
Hey.